welcome to another week in which I totally deviate from the planned topic. Um, Great. So this week we're going to talk about the state of pediatric antiretrovirals and antimalarials, specifically in the context of sub-Saharan Africa, with emphasis on Rwanda and Malawi, because those are the two countries I was looking at for this particular project. And so some of the key abbreviations we'll be touching on in the presentation are P. falciparum, which is Plasmodium falciparum. It is the primary disease-causing agent in these two countries, as opposed to other species like Vivox and others that are prevalent in other countries. ART just generally stands for antiretroviral therapy, and in this context is used to control HIV, which is often can often co-infect individuals with malaria. LPV/R is lopinavir ritonavir, and this is just one antiretroviral combo I was looking at. And then NRTIs and NNRTIs are nucleoside reverse transcriptase inhibitors or non-nucleoside reverse transcriptase inhibitors. They are another key component of these anti-HIV cocktails that are used to control the viral load. And lastly, AL is this highly specific combo, artemether and lumefantrine, which is a common antimalarial. But before we really get into it, I do want to take a moment and gloss over or talk about oral pharmacokinetics at a high level. And so I put this slide together like 15 seconds ago, where what we're looking at here is plasma drug concentration over time. And what you'll notice is that there's multiple phases to this concentration profile, where initially you have this absorption phase where the drug is being absorbed through your gut or through your buccal membranes, among other areas. It reaches this peak concentration called a Cmax, and the time to reach that concentration is called Tmax, which might show up in abbreviations somewhere. But after essentially you reach the Cmax, the body begins to eliminate the drug from the blood. Typically, this is through renal or hepatic clearance, and so you eventually reach this elimination phase, which can be first order, can be zero order, or can be much more complex once you start incorporating the saturable mechanisms and enzymes. And so now we can jump straight into this current state of antimalarials in Africa. And so the one I was focusing on for this project was artemether lumefantrine, abbreviated AL. And so 65.3% of countries in WHO African region includes AL among its frontline therapies for malaria, or especially for uncomplicated malaria. And then as you fail the initial or first line pharmacotherapy, you move on to a treatment failure regimen, which can include quinine or artesunate and other drugs. And then failing that, you then move on to another backup regimen for severe malaria. And in fact, almost a third of these countries actually have artemether lumefantrine as their sole frontline therapy, and Rwanda and Malawi certainly fall into this category. So it became fairly clear very early on that these two drugs are very important in combating malaria. And because we're focusing, or because I was focusing on pediatric formulations and pediatric co-infection of HIV and malaria, I wanted to look at the state of recommended first antiretroviral therapies. And so depending on the age of the child as well as the weight of the child, there are a number of different antiretrovirals that can be prescribed. And what we'll notice here is that lopinavir and ritonavir are present among these preferred initial therapies for antiretroviral therapy naive children, especially for children between 2 weeks and 3 years of age. It is alongside raltegravir the recommended first-line therapy. And then if anyone's familiar with darunavir or HIV antiretrovirals in general, they would note that darunavir is the best-in-class protease inhibitor, but it's not approved in children under 3 years because there were some preclinical studies in, I think, neonatal rats where the drug caused convulsions. And so it's not recommended for use in this critical time window of a child's development. So the question was, if a child becomes co-infected with HIV and malaria, will these two drugs have any drug-drug interactions that could potentially reduce the efficacy of one drug or or even exacerbate the half-life in blood. And so something I do want to mention that I forgot to touch on this slide. Some two key things we want to talk about are AUC, which stands for area under the curve, and generally that's just integrating a discrete number of time points, and then you can compare AUCs between two different PK profiles. And by doing so, you can then compare drug exposure. And so drug exposure is directly related to the area under the curve of each of these PK profiles. And so you might imagine if there's a drug-drug interaction where for some reason the PK or the drug is being eliminated more quickly, you might expect a steeper elimination phase. And then as a result, you'd have a lower AUC and thus lower drug exposure. That's how we would quantify such a metric. Great. So now there are three topics I want to touch on as we move into this question of do these two different drug classes have any interactions that could potentially be beneficial or harmful to the children? We see that, or we'll establish that lopinavir ritonavir extends lumefantrine half-life safely. And it does so by inhibiting CYP3A4, which is a liver enzyme. That's the primary route of elimination of lumefantrine. And by inhibiting that route of elimination, lumefantrine is persisting in the plasma longer and actually conferring protection against malaria longer. Whereas some other antiretroviral therapies like NNRTIs, these actually induce this enzyme and cause lumefantrine to be metabolized more quickly, reducing its half-life and reducing the amount of time it remains above an efficacious concentration in the blood, and thus diminishing protection against malaria. Secondly, we want to think, great, it seems like we should combine lopinavir and ritonavir with lumefantrine because we're extending the antimalaria protection. But what if this protease inhibitor combo is actually less effective at combating HIV or controlling HIV viral load? And so there's another study I'll show that shows, in fact, it is non-inferior to NNRTI for HIV control, and there's no difference in viral suppression, time to failure, changes in CD4 positive T cells, or severe adverse events. And then lastly, if we have time, we'll talk about some pharmacokinetic effects in other populations, particularly adults and pregnant women. Great, so jumping straight into the first point, which is related to the pharmacokinetics and elimination of lumefantrine. And so in this study, they show that lopinavir ritonavir associated elevation in lumefantrine exposure reduces the risk of recurrent malaria. So not the initial incidence of malaria, but actually the risk of having a recurrent episode of malaria. And so in this case, they had some HIV positive children that were between the ages of 2 months and 5 years. And then they randomized them into two groups. My cat is going crazy. One received lopinavir ritonavir with 2 nucleoside reverse transcriptase inhibitors. The other received NNRTI plus 2 NRTIs. So the NNRTI in these cases are either efavirenz or nevirapine. And then the NRTIs were lamivudine plus zidovudine, or in some cases, zidovudine was replaced in anemic children with certain other drugs. And lastly, having placed and randomized these two HIV positive children groups into two groups, if there were cases of malaria or incidences of malaria, they would then treat ad hoc with artemether lumefantrine as recommended by WHO. And so this study was conducted in Uganda, which is primarily P. falciparum. So we are looking at the same species as in Rwanda and Malawi. And so what they found is that if we start on the left, between the two different ART therapies, there was no difference in the initial risk of malaria. And so you're seeing P equals 0.14, and this is just cumulative risk of first episode of malaria. But actually, if we look at a different metric, which is the cumulative risk of recurrent episodes of malaria, we see that the lopinavir ritonavir based ART actually significantly reduces that cumulative risk. And then, okay, so this slide is further evidence that this might be related to the PK changes elicited by the lopinavir ritonavir based ART. And so what we're going to look at is on the left is NNRTI based ART. Each of these traces So what they did is on day 7 after lumefantrine administration, they looked at how much or what was the concentration of lumefantrine remaining in that child's blood or plasma. And so they separated those into 3 buckets. One was less than 300 nanograms per mil, one was between 300 and 700, and the other is more than 700. And what they see is regardless of what the day 7 concentration of lumefantrine was, there was no difference in the cumulative risk of recurrent episodes of malaria. Whereas when we look at the lopinavir-ritonavir-based ART, the 2 groups that had above 300 nanograms per mil of lumefantrine remaining in their blood actually had a reduced risk of recurrent malaria, suggesting that the presence of additional lumefantrine at that later time point conferred protection against a second episode of malaria. And so what they're hypothesizing in their discussion is that lopinavir extends the half-life of lumefantrine, which retains concentrations at clinically efficacious levels, which is then reducing the risk of malaria recurrence. And if we think about this, it makes sense that there's no difference in the initial risk. If the HIV drugs are not having a direct anti-malarial effect, and they're not receiving antimalarials, then the 2 groups should be identical in risk of malaria. But then after that AL therapy is initiated, the lopinavir-ritonavir group should have inhibition of CYP3A4, reduced lumefantrine clearance, elevated lumefantrine at day 7, and thus a longer duration of protection against second incidence of malaria. And so they do attribute this difference to inhibition of CYP3A4, although they don't show it mechanistically, but they do cite a couple of papers that this is consistent with. In a second study, we're seeing that not only does this pharmacokinetic effect happen, but it actually improves clinical outcomes for malaria. So in this case, they're actually enrolling malaria-infected children between 6 months and 8 years. And so with the HIV-negative children who had malaria, they didn't put them on antiretroviral therapy. And with the HIV-positive, they randomized them into 3 groups. One was efavirenz, one was nevirapine, and one was lopinavir-ritonavir. So same drugs as in the last study. And what they did is, because they had malaria, they initiated 6-dose treatment of artemether lumefantrine, and then they did intensive pharmacokinetic sampling. And so again, this is conducted in Uganda. And what we essentially see is in the artemether lumefantrine combination, lopinavir-ritonavir did not affect artemether PK, even though we've just seen it affects lumefantrine PK. But in fact, the NNRTI, so efavirenz and nevirapine, significantly reduce artemether Cmax, AUC, and the concentration at 24 hours. And so what we're looking at, the black traces are negative control. The lopinavir group is cyan, which is insignificant, statistically insignificantly different from the black trace. And then the efavirenz and nevirapine have significantly lower Cmaxes and significantly lower AUCs. Now, if we start looking at the lumefantrine PK, so as indicated or consistent with the previous study, we see that efavirenz lowers lumefantrine PK or lowers lumefantrine AUC, whereas lopinavir-ritonavir increases lumefantrine Cmax and AUC. And so again, we're looking at lumefantrine concentration in the plasma, and we see that that light blue curve is actually extended above and for a longer duration than the black curve, which is the negative control, and then efavirenz is on the other side of that negative control. And then again, this is just another way of representing that it reduced the risk of malaria recurrence. So we're looking at this light blue trace, which is much lower than the negative control and the others that received antiretroviral therapy. Great, so we've shown that lopinavir-ritonavir can increase the half-life, the terminal half-life of lumefantrine, and thus confer protection against recurrent malaria. And now we want to jump into a study that shows it in fact protects just as well as other antiretroviral therapies against HIV. And so in this study, we're looking at clinical outcomes from different antiviral therapy cocktails. And so what they have is HIV positive children randomized into two groups, one or the other. Should look very familiar by now. And then they do a 96-week follow-up analysis. And this is again in Uganda. I keep changing my pronunciation of that. I gotta figure that out. But in any case, what we're looking at on the left is a time to virologic failure. I should have pulled out how they defined that in the paper, but nevertheless, what we're looking at are statistically insignificant deviations from between the two curves. And so essentially we're showing that lopinavir is non-inferior to NNRTIs for controlling that metric. And there's no difference in CD4 positive T counts, which are the primary victims of progressive HIV. And so that's shown here between these two traces. Yeah, and so we've shown essentially that LPVR protects against malaria and it doesn't suck at protecting against HIV. And then as a quick aside, I didn't pull these studies out explicitly, but I think it's nice to show that these effects in pediatric populations can be replicated in adults. And so in this study, lumefantrine exposure was increased among adults who received lopinavir ritonavir and was decreased in patients that received efavirenz, which is our NNRTI, as well as rifampin, which is a well-known antitubercular, which is a CYP3A4 inducer. And so again, that makes sense and is consistent with the idea that CYP3A4 is playing a critical role in this lumefantrine PK effect. Another study in adults, again, it's a population pharmacokinetic analysis of several studies pulled together. Same results are lopinavir ritonavir extended lumefantrine exposure, whereas efavirenz and nevirapine decreased lumefantrine exposure. And then, unfortunately, these effects, while they were shown to be significant in adults, did not result in benefit to pregnant women. And so what we're looking at are HIV-positive pregnant women that received either LPVR antiretroviral therapy or efavirenz-based antiretroviral therapy, and essentially they had the same rate of malaria, placental malaria, and the incidence risk ratio was 1.01, so essentially identical. Yes, and yeah, thanks. Do we have any questions? One of these labels must be wrong.